fashion, a pulsatile stimulation of GnRH receptor will lead to what? It's actually causes what? Stimulation of the axis. Leads to release of LH, FSH, right? But continuous, right, stimulation of GnRH receptor actually has an inhibitory effect. But I don't really know why, but probably because the receptor might become desensitized. If I'm stimulating something too much, right? It may become desensitized and will stop responding. Yeah. So if you're given a GnRH agonist in a pulsatile fashion, goserelin and leprolide, the pulsatile fashion, they're going to stimulate the axis. So you can use them to treat maybe conditions where patients are infertile. Somebody came in with infertility because of maybe amenorrhea, because of anovulation, right? I want to stimulate the axis to help trigger ovulation. I might use pulsatile, GnRH agonist. On the other hand, if I want to suppress the axis, then I'm going to give GnRH agonist in a continuous fashion, like high dose continuous fashion, so that there will be continuous stimulation of the receptor, and it's going to shut down the axis in that case. Even if your initial intention, if your initial intention is to suppress the axis, when you initiate GnRH agonist, it's gonna be stimulating, the receptor in the pulsatile fashion first, because the patient just started taking the drug. The level in the blood is not that high yet. So there will be unavoidable, initial stimulation of the receptor before we now achieve, high enough concentration, to cause continuous stimulation and suppression of the axis. Make sense? So that is why. Imagine somebody has prostate cancer. You start them on GnRH receptor agonist. They can actually suffer what? Flare up of the tumor, because there will be initial stimulation of the axis, testosterone will be high, DHT will be high, there will be initial stimulation of the cancer cells. And the patient, let's say the patient has vertebral metastasis, the pain will be worse initially. But if we keep giving the drug, eventually, there will be continuous stimulation, suppression of the axis, and these cancer cells will start shrinking, and their symptoms will abate. And which begs the question why. So this is why initially when you start GnRH receptor agonist in somebody with prostate cancer, what do? You must give them what? A testosterone receptor blocker or androgen receptor blocker simultaneously. So that initial flare up, will not be what? Will not be felt by the patient. That initial stimulation will not get to the what? The cancer cells. By blocking the receptors, even though testosterone will be high initially, it will not be able to stimulate the receptors, and the cancer cells will not grow during that initial phase. And then once you achieve inhibition, you can stop, the androgen receptor blockers like flutamide. Yeah, that's a broad question. Yes. Clomiphene is another drug, that works on estrogen receptor in the pituitary gland. Clomiphene is class of drug we call what? SERMs, Selective estrogen receptor modulators. Other drugs in that class are what? Tamoxifen and raloxifene. What clomiphene does in to estrogen receptor in the pituitary gland is it blocks, the receptor, right? Blocks estrogen receptor in the pituitary gland or on the pituitary gland, the gonadotropes. And by doing so, that actually activates. It activates the axis. It stimulates the release of LH, and FSH. Question is why? Why would blocking estrogen receptor stimulate release of LH-FSH in the pituitary gland? Exactly. Good. So it's gonna block this feedback, right? Inhibition, yeah, of LH-FSH, right? So clomiphene 2 is like fertility drug, can trigger ovulation and help, yeah, with fertility.